Hello, my name is Dr. András Székely. I am a chest radiologist in Debrecen, Hungary. I have prepared this video for you on behalf of the European Society of Radiology. Today, I am going to talk to you a little bit about the virus that is causing this pandemic, about the guidelines on the use of CT, and then I am going to discuss in detail the CT features of COVID-19 pneumonia. So let's get started. The goal of this presentation is to help you in situations when you encounter a patient or you see CT morphology that is suspicious for COVID-19 pneumonia. I do hope that you will never need to use what you will have learned today. Nevertheless, this presentation will be available for you anytime. I have nothing to disclose. And here are the learning objectives. So I would like you to gain some basic knowledge on the COVID-19 coronavirus. I would like to help you understand some of the current imaging guidelines and to help you familiarize yourselves with reporting templates in COVID-19 pneumonia. And the backbone of the presentation will be learning the typical, indeterminate, and atypical CT appearance of COVID-19 pneumonia. So just a couple words on the pandemic and the virus that is causing it. The SARS-CoV-2, which is responsible for the pandemic, was identified late last year in China at a local seafood market. The disease presents with various symptoms, such as fever, dry cough, breathing difficulties, and fatigue. However, lately, enteral symptoms have been reported. 80% of the patients will have mild flu-like symptoms, and 20% will require medical attention. The latter of these patients will either require hospitalization or ICU care. A couple words on the virus. So the name is COVID-19 or SARS-CoV-2, and this virus is also a beta coronavirus. It is closely related to the SARS-CoV-1, which you might recall from 2003. That virus also caused a pandemic and reached various parts of Europe and even the United States. The MERS, which is the Middle Eastern Respiratory Syndrome virus, is the distant cousin of it. SARS-CoV-2 also uses the ACE2 receptor for cell entry, so the virus lands on these receptors and induces endocytosis. The ACE2 receptors are found in the lungs and the kidneys, and the virus can cause direct lung damage and induce apoptosis in the liver and the kidneys. Now, some of you who are listening to this presentation might be at home with elementary school children. It is good news for you that it seems that the expression of the ACE2 receptors are not complete in childhood, and children encounter alpha coronaviruses frequently, and the antibodies that our bodies produce against these alpha coronaviruses might protect against the betas as well. For further comfort, let me remind you of a study that came out of China late last year that talks about a family of 6 in which only the 7-year-old child wasn't infected. For her, both the CT and the PCR studies came back negative. The SARS-CoV-2 is about 96% identical to a coronavirus that was discovered in bats previously. However, in one specific part of the RNA, they are not similar at all. This part actually codes the protein that binds the virus to the ACE2 receptor. It seems that the RNA of COVID-19 that codes the binding protein is similar to another beta coronavirus that lives in the pangolins. Therefore, at present, the scientific belief is that SARS-CoV-2 or COVID-19 is a chimera that wasn't cooked up in a lab. Rather, it is a result of natural selection. Let's turn our attention to the guidelines. There are several recommendations available, and I tried to synthesize these for you. First and foremost, CT should not be used to screen for COVID-19 or to replace the PCR study. There is no imaging recommended if there is a patient who has clinical suspicion of COVID-19, but doesn't need hospitalization. No imaging is recommended for patients who are hospitalized but are not deteriorating or even improving, or for patients who are at the end of their treatment. In certain cases, CT is recommended, preferably a non-enhanced low-dose CT of the chest. So this would be patients who are hospitalized and are showing signs of deterioration, or in specific cases when the PCR study is negative, but the clinical suspicion for COVID-19 is high. In this case, the clinician should come to us, discuss the case with us, and then we will do the CT. And as I said, the CT should be a non-enhanced low-dose CT, but in certain situations when there are suspicions for other pathologies, such as pulmonary embolism, then IV contrast might be given to the patient. Just a couple words about the recommendations in Hungary. For this, you need to know that testing per capita is very low in Hungary compared to the neighboring countries. All the patients who come from the ER or who are going on to acute surgery and they require a CT anyways of another region, then LDCT of the chest will be performed. If there is acute surgery, but the PCR is not available or uncertain, but the clinical suspicion of COVID-19 is high, then we will consult with the clinician, and if he or she wants it, then we will perform low-dose CT of the chest. In case of acute or elective surgery and a negative PCR, but if the patient shows signs of lower respiratory disease, then we will perform the low-dose CT of the chest if, again, the clinician wants it. In case you need to report a CT of a patient who is suspected of having COVID-19 pneumonia, structured reporting templates might be helpful to you. These templates are available in various languages, such as English, French, and German, and they may be helpful for you in identifying the main features of COVID-19 that I'm going to talk about later in this presentation. The templates might also be helpful in quantifying disease severity. So with these spreadsheets, you can report how much the different lobes are affected. You just need to click on these radio buttons, and then the template will automatically generate a number at the end of the report. And then the rest of the organs can be reported in the usual manner. Speaking of which, here are the things that you should report. You should report if you see typical, indeterminate, or atypical CT findings of COVID-19 pneumonia, and you should definitely report if there are no signs of pneumonia at all. Let's start with the typical CT findings that are usually reported for COVID-19 pneumonia and in the right clinical context are very likely to be due to COVID-19. In these cases, you can write under impression that CT findings that are usually reported in patients with COVID-19 are present. First on the list of typical CT findings of COVID-19 pneumonia are bilateral peripheral ground glass opacities or ground glass opacities and consolidations. By definition, a ground glass opacity is an area with increased density that doesn't hide the underlying vessels, bronchi, etc. On the other hand, the consolidation obscures the underlying parenchyma. Multifocal round ground glass opacities and consolidations may also be another typical CT finding, and I believe this was the first published sign of COVID-19 pneumonia. You can see how round these ground glass opacities are, and on this image you can see that these ground glass opacities and consolidations are multifocal. Now, I mentioned that the clinical context and the PCR information is very important for us, and here's a case to illustrate that. This patient had also high fever, he was hypoxemic, and as you can see on the CT, there are multiple areas of ground glass opacities and consolidations. There is also septal thickening. So up to here, you could say that this patient is suspicious of having COVID-19 pneumonia. However, there was pleural effusion, and the bronchoalveolar lavage showed the presence of eosinophils, and so the final diagnosis was eosinophilic pneumonia. If you see the previous findings, so the peripheral or multifocal ground glass opacities, plus or minus consolidations, and crazy paving, that might also be a typical finding of pneumonia, COVID-19 pneumonia. However, you should know that crazy paving is not a specific sign. By definition, it is a GGO with the reticular pattern. So here you can see the outlined secondary pulmonary lobules and the inter- and intralobular septal thickening. Crazy paving might be caused by various diseases such as proteinosis, adenocarcinoma, hemorrhage, etc. Here's a case of pneumocystic carinii pneumonia with the bilateral crazy paving, then quite diffuse. Here's an image of a cobblestone street that will help you remember how crazy paving will look like on the CT. So in this case, the stones would be the secondary pulmonary lobules, and the cement surrounding the stones would be the interlobular septa. If you see, again, the previous findings, the ground glass opacities and the consolidations that are peripheral and multifocal, plus you see the so-called reverse halo sign or atoll sign that might also be signaling COVID-19 pneumonia. An atoll is a ring-shaped coral reef, which I haven't seen before, but it looks quite pretty. In radiology, this I've seen, is a central GGO that is surrounded by consolidation that is at least 2 millimeters thick. Again, it's also not specific for anything because a lot of various diseases might cause it, such as infarcts, fungi, sarcoid, irradiation, or adenocarcinoma, but it can show up for COVID-19 pneumonia, and here's a case to illustrate that. So here you see the peripheral multifocal ground glass opacities, maybe even some consolidations, and then in the right upper lobe you can see the atoll sign or reverse halo sign. In later stages of the disease, we might see typical signs of organizing pneumonia, so these bilateral, peripheral, and peribronchovascular consolidations that appear nodular or mass-like, and they are interspersed with healthy tissues. And what is not obvious from this one slice is that this morphology is more pronounced in the basal segments, and this was actually a case of COVID-19 pneumonia. Another sign of organizing pneumonia is the so-called perilobular opacity, which doesn't necessarily highlight the edges of the secondary pulmonary lobules, because these opacities are actually thicker than the wall or septum of the secondary pulmonary lobule. Here you can see the nice and thin septae of the secondary pulmonary lobule. So this is not COVID-19 pneumonia and not organizing pneumonia. And in later stages of the disease, later stages of organizing pneumonia, you might see the so-called arcade sign, in which these perilobular opacities resemble the arcades of this bridge, for example, and there are dilated bronchi, which are signaling that some form of fibrosis is going on in the background as well. Subsegmental vascular enlargement, I have only read about this in 3 different articles in regards to COVID-19 pneumonia, and it's described as a subsegmental vascular enlargement larger than 3 millimeters in or in the vicinity of the ground glass opacity, and it is different than the tortuous vascular enlargement that you might see in malignant type of ground glass opacities. This presentation wouldn't be complete without me discussing the appearance of this disease in children. And it's no surprise that even in children, we expect to see uni or bilateral peripheral ground glass opacities with or without consolidations. At present, consolidations surrounded by ground glass opacities are thought to be the typical signs of COVID-19 in children. Pleural effusion is something that we do not expect. Up to now, we discussed the typical features of the disease, and now let's move on to the indeterminate signs which signal the presence of COVID-19 with moderate confidence. If you see these lesions and patterns, then in your report you should state that these signs are not specific because several other lesions might be the cause of them. Ground glass opacities and consolidations without a clear distribution and that are not rounded should not be interpreted as typical signs of COVID-19 pneumonia. And here's a case to illustrate that. This was a 29-year-old male who was admitted to the hospital and eventually required ICU treatment due to fever and dry cough and, of course, difficulty in breathing. And on the CT, you can see that there are various areas of ground glass opacities, consolidations that are bilateral, but they lack a clear distribution. However, if we go a couple slices further down and observe the basal segments, you can see at the level of the middle lobe and the right lower lobe that the disease clearly affects the peripheral areas, and this actually turned out to be a COVID-19 pneumonia case. Another case which might be similar to the one that we saw before. So again, various areas of ground glass opacities and consolidations, which partially peripheral, partially peribronchovascular, and some septal thickening is also visible. However, there are bilateral pleural effusions, which is not typical for COVID-19 pneumonia, and this actually didn't turn out to be a COVID case. This was a case of Boca parvovirus infection. And here's a case from our hospital. She was the first patient who was suspected of having COVID-19 pneumonia. She is a 39-year-old female who presented to us with cough, fever, and dyspnea, and eventually required mechanical ventilation. You can see that the CT shows bilateral geographic subsegmental GGOs, which in one slice is perihilar, in other slices it's more peripheral, so it doesn't follow the typical COVID-19 pattern. There was also a small amount of pleural effusion on the right, but this patient had 3 negative PCR tests, so this was a definite non-COVID-19 pneumonia case. Unilateral ground glass opacities, with or without consolidation, that are not peripheral and not rounded, are not typical features of COVID-19. The reason I'm showing you this image is because I think this case nicely demonstrates how subjective the interpretation process might be. I'm sure if 10 radiologists were to look at this right lower lobe ground glass opacity, they would all agree that it is peripheral. On the other hand, some would say that it is triangular, others would consider it trapezoid, and yes, some would say that it is rounded. Here are some non-rounded and non-peripheral ground glass opacities that we saw about half a year ago when COVID-19 wasn't even on the radar. These patients took part in our national lung cancer screening trial, so they were asymptomatic, heavy smokers. And I'm sure that most of you know very well that it is common to see a couple nodules in these types of patients. So we have arrived to the green zone, where we find CT signs that are atypical or rarely reported in COVID-19. If you see these, then you should consult the clinician and tell her or tell him to consider alternative diagnoses. For example, if you see consolidation in a segmental or lobar distribution, especially if it's without ground glass opacity, then you should not think of viral pneumonia, and none of these were viral pneumonias. If discrete nodules are visible, you shouldn't think of COVID-19 pneumonia automatically. Here is a coronal slice from a 53-year-old male who had a liver transplant, and you can see the bilateral multiple solid nodules that are surrounded by faint ground glass opacities, and this turned out to be a CMV infection. On the right is an axial MIP image from a 39-year-old male who was diagnosed with tuberculosis, and here you can see the typical tree in bud sign. Cavitation hasn't been reported for COVID-19 pneumonia, and this was a case of bacterial pneumonia that later showed complete regression. If you see smooth septal thickening plus pleural effusion, which is the pulmonary edema pattern, then you shouldn't automatically think of COVID-19, even if it comes with various degrees of GGO or consolidation. In these cases, you should carefully examine all the CT slices, and then you will probably pick up the typical pattern, which is more pronounced on the dependent side of the lungs. As you recall, the typical CT findings of COVID-19 are bilateral, peripheral, and they are more pronounced in the dorsal-basal segments. Here I am showing you two cases which are almost exactly the opposite of that. So a case of bilateral perihilar ground glass opacities in a case of pneumocystis jirovecii pneumonia, and another case of perihilar ground glass opacities, consolidations, accompanied by bilateral pleural effusions in a case of acute pulmonary edema. Subpleural reticulation with or without GGO, also known as the fibrotic pattern, is not a sign of acute COVID-19 pneumonia. However, I'm still showing you these images because if you think back to 2004, 2005, when the first SARS pandemic died down, you might recall that we saw an increase in the number of fibrotic cases in patients who suffered from SARS-1. And I believe that if today's pandemic dies down, we are going to see quite a lot of number of patients with fibrosis who also suffered from COVID-19. So as a reminder, here's the typical UIP pattern with the subpleural, dorsal-basal reticulation and honeycombing. However, UIP might not be so conspicuous. Sometimes you just see the dorsal-basal faint reticulation with very discrete ground glass opacities. However, these abnormalities will persist even in the prone position. And as I said, you should definitely write down if you see no signs of pneumonia, because that's also very helpful and reassuring for the clinician. But I would like to mention that in the early stages of COVID-19 pneumonia, CT might not show any abnormalities at all. So with that in mind, let's take a look at this right lower lobe peripheral crescent-shaped GGO, which I hope that nobody would report as a result of COVID-19 pneumonia, because if you look at the coronal slice, you see that this is just due to some spondylophytes, and this is called paraspinal ground glass opacity, which we encounter in virtually every second patient above a certain age. Maybe I am saying this because I come from Hungary, where the morbidity and the mortality of lung cancer is the highest. But if you see a large ground glass opacity, whether it is peripheral or not, you should always consider the possibility of lung cancer, especially if it's an older, heavy smoker patient. And to illustrate this, here is the CT image of a 55-year-old male who is also a heavy smoker, and we saw this large right upper lobe part solid nodule, which showed considerable amount of change compared to last year's image. Even in 2020, this peripheral area with increased opacity should not be regarded to be the result of anything else other than lung cancer. So please do not forget about lung cancer. And with that, I would like to thank you for your attention. I hope you enjoyed listening to this presentation as much as I did preparing it and presenting it to you. And I hope to see you in Vienna very soon.